Hello, everyone, and welcome to another day of the Pandemic, Science, and Society. Our first speaker today is Dr. Ali Ellebedy from Washington University School of Medicine. He will be discussing immunity and therapeutic interventions against SARS-CoV-2. Welcome, Dr. Ellebedy.
Thanks, Krista. Thank you so much. Okay, should I share my screen now? Okay. I hope everyone can see my screen now, and I think I can. Thank you. Let's see if I can put that. Okay, so first, thank you for inviting me to be part of this exciting lecture series. So my name is Ali Ellebedy, as Chris mentioned, and I'm going to share with you today some of the work actually that we have been doing in the lab in the last few months. And basically, just to give you a very brief overview, that we have been, our goal has been really try to develop a therapeutic intervention that we are hoping that we will get it to the clinic to treat for treatment of patients infected, and potentially we can have it used as a prophylactic at certain point. And the very exciting development, it's not there yet, but it's very close, that some of these molecules that we have been developing are getting very close to be licensed, which is the next stage for it to be prepared by usually a large pharmaceutical company for making it as a drug, and you apply for the FDA and all of the detailed steps after that. So we are not there yet, but we are very close, and I'm going to share with you how the different steps we took to actually reach to that stage, which is very exciting for us because we really didn't have. We always work on the bench, and we really aspire to actually have something that we can contribute to be a real drug clinical material. So I will start by very general, but before I start, I really, because I'm really not good at giving the acknowledgement at the end. So I usually get excited about answering the questions and forget to the most important part, to thank the people actually involved in the work and really made that happen, not really myself. So I will start by that, and I will just say that this work has been done with a really fabulous group of people in my lab that has been working really hard in the last 6 months, literally from the second week in March, when we really dropped everything and started working on these data that I'm going to share with you. But also there's wonderful collaborators, starting from Weiling, which is one of the pioneers in using what I'm going to show you data from. Very exciting, the hamster model, to test the interventions or the countermeasures that we can make. If you want to make a molecule that you think can cure or can prevent the infection, then you want to test it in an animal model. And the hamster model, and I'm going to discuss this in detail, has been the best model. And Weiling, she is in University of Hong Kong. She is basically the world-class pioneer of using that model for SARS, and I'm sure some data from that. I have a very close relation and interaction or collaboration with Mike Diamond Lab here at WashU School of Medicine. And also some of the slides that I'm going to present, especially in the beginning introduction, are actually shared with me from Mike. So these are Mike's slides. Some of the data from David Fremont Lab, again, very close collaboration in preparing these drugs. Also, we had collaboration with Steve Kleinstein at Yale and Florian Kramer, who very generously shared some of their reagents with us from School of Medicine at Mount Sinai. Obviously, we are very grateful for the funding from NIH to do all this work. So with that on the side, again, this work was led mainly by Wafa Al-Susi. She was actually a visiting scientist from Beirut that spent a year and a half in my lab, and next week she's starting in the grad school here at WashU in Immunology. And this Wafa worked closely with Jackson Turner, who's a postdoc fellow, and with Aaron Schmetz, who is our lab specialist, research lab specialist, and the three of them really spearheaded this effort in my lab. So let's start with where we are at the moment, and probably this is something that many of you really know, and it's not something new. We have now over, last time I checked, it's 25 million infections, confirmed infections as reported by the WHO, and there is close to or more than 800,000 deaths globally from this pandemic. This is obviously a huge toll that this pandemic has taken on us. And it's not over yet, although we are seeing some good signs, at least in the US. Very, very, very small improvement. I mean, we are really decreasing, but really we are not there yet. And this is just to make sure that no one really make sure that we are all still have practiced all the right things, because as you can see, this is over the last week from the WHO, and I'm sure there's a lot of underreporting going in some parts of the world because of for many reasons, and I think this is probably, the numbers are probably more than that, but you can just see that we are not out of the woods yet. So one thing that we heard a lot at the start of this pandemic is, it is just a flu. And being someone who actually has been working with flu for 15 years, I sometimes wish if it was just a flu, but unfortunately it is not just a flu. And this is something that I want to share to show you that we know we had the flu for a long time. We know what the flu is. We know what the flu virus, which is obviously referring to influenza virus, what influenza virus can do. And I'm not an epidemiologist by any measure, so I'm not going to really claim that I can explain all these numbers. But one thing that I just probably just want to draw your attention to is the case fatality rate of seasonal influenza is nothing compared to COVID-19. And again, this is probably something that, these numbers can be updated and can change over time, but obviously we are not close even. And the other thing that's very intriguing to us as immunologists is that really the incubation time that we see very, very variable, but also it's significantly longer, seems to be, for this virus, the SARS-CoV-2 virus, compared to even the viruses that were the same coronavirus, beta coronavirus family, SARS, the first SARS, and the Middle East respiratory syndrome virus, the MERS. Both of them, we didn't see that long incubation time, and we can think that this is a factor that affects obviously the transmission. If you're not showing symptoms quickly, you can start transmitting before you get really symptomatic. So one thing we do know is like flu, SARS-CoV-2 is a respiratory virus. So it shares with influenza that it is a virus that can actually infect all the way to the lower respiratory tract, causing this pneumonia. Obviously, influenza can infect all parts of the respiratory tract, upper and lower. So it does, obviously, and we very rarely we can see, I don't think there has been documented any case of a systemic infection, meaning that think about viruses like Ebola, which basically every tissue in the body can be, theoretically can be infected. The virus goes systemic in that case. In our case, with SARS-CoV-2, like influenza, it's mainly a respiratory tract infection. It's confined to the respiratory tract, at least productive infection is. But also what we learned in the last few months, that it's even more than just a respiratory virus, because although that we do have the typical presentations that we get with almost like flu, the fever, the cough, the whole myalgia, all the discomfort that we see with flu. But then even with flu, we can actually see sometimes diarrhea as well. But then what we see here also is something we don't see with flu, which obviously neurological complication. This is something very rarely happens with influenza. It's not really rarely in that case with COVID-19. And obviously all the ERDS, which is the acute respiratory distress, this is really something common. And unfortunately, most of these severe presentations are leading to the high fatality rate we see. As I said, I'm not an epidemiologist, so I'm not going to I'm sure you guys will have a chance or had a chance to talk about details about what are the comorbidities how these comorbidities affecting the infection rate and the fatality rate, but it's very, very clear that there are cardiovascular people with cardiovascular disease or history of cardiovascular disease or obviously diabetes or hypertension are really at high risk. So this is something that, when you look at the data, it's very clear, and obviously age as well. So again, it's more than a coronavirus. It's not more. It's more than just a respiratory virus. And one of the things that when you see this, you realize right away. It reminds me of an article that a really great article written by an army epidemiologist in 1919. So if you remember, in 1918 there was an influenza pandemic, an H1N1 influenza pandemic, also known as the Spanish flu. Some of you might know about that. But and this pandemic, it's really picked up at the end of the First World War. And it's really, the estimates are 20 to 50 million people worldwide have died by this pandemic. So it's obviously a devastating one. But even a year later, so was literally a year after the pandemic, where there's, I guess, after the second wave of it, and then there was this really, I think it's very, very wise words that have been said that really we cannot, even at that time, even a year after the start, there are lots of things that we don't know. And that's why I mentioned earlier that some of these numbers or stats about the case fatality rate, about the R node of this virus, there are lots of updates because we are still living in the event. We are living through it. So it's always different when hopefully soon, but probably not too soon, we'll get out of this and now look back and start look at the numbers and see what we can learn. But at this moment, I totally agree with this part. We cannot really say anything definitively about this, especially when it comes to many things about the pathogenesis, about durability of immunity, and this is something we will discuss. But I think this was a great article written at the time. So, I think it's worth reading. So, the one thing that we all know that we need a vaccine, and again, this is something that I don't know if I need to point this out for this audience, but we know that vaccination probably and we all realize that vaccine is probably the best way for us to control this pandemic, or the most efficient way to end it, actually. And we have seen this throughout history that really vaccination is the most successful intervention against infectious disease. You can really preventing infectious disease, especially viral infections. You can look at polio, you can look at measles. These are the years you look at. This was 8 years ago. Polio 70 years ago, polio, and less than that for measles were really a huge problem. And of course, once we have the vaccine introduced, we can see the huge decrease in cases. So there's no doubt about the huge impact that vaccine will do. And I think that's why we all should strive to make sure this is going to be our best strategy to get out of this pandemic. And just to, as I said, polio made obviously it's a very clear example for how things made very successful in terms of controlling this outbreak or this infection. And just a very clear images, this is the polio in 1988, and this is wild polio virus. And if you looked at 2008, we have only a few pockets left. These pockets was again, we're talking about wild polio virus, were in Nigeria and Africa, and in some areas in Southeast Asia. And I don't know if you're following the news, but the last 2 weeks, there are reports that really Africa is becoming free of polio virus. So we are really getting very, very close to get rid of wild polio virus. I think this is within sight at this stage. So this is great news. This is exciting. But so how we can, at that time, all of these viruses that we developed vaccine on, again, 50, 60, 70, 80 years ago, we were very limited in terms of our approach to develop these vaccines. And just to, as I said, polio 1988, and this is wild polio virus. And if you looked at 2008, we have only a few pockets left. This was The most famous or the most commonly used approach is just take the virus and inactivate it, basically put it in some chemical like formalin, and that virus now is inactivated, and then you just inject it in people and induce an immunity that I'm going to discuss how this happens in a few slides. Um, More advanced we use with polio is really live bacterial virus, where you can actually grow the virus in a cell line that's or in a kind of cells that are not used for it. For example, you take the human virus and grow it in a monkey cell line. The, and then the resultant virus will be very weakened virus when it infects human, and you can use that, although it has some drawbacks. Um, but since that time, we have developed a lot of different modalities to or different approaches to get vaccines. For example, the split vaccine. After you inactivate the virus, you actually split it with some detergents. And some of the influenza vaccines have actually, the annual influenza vaccines are made this way. We have done virus-like particles, DNA or RNA vaccine, this is the most advanced, and if you are following the news, some of the most advanced COVID vaccines are RNA-based vaccines. I'm going to talk about that. But also you can use something called a viral vector, which is use a virus that you use virus as a vector, like adenoviruses, for example, and these usually are non-pathogenic, and you actually engineer it to express a particular molecule of interest. And in that case, you express the molecules of SARS-CoV-2. And again, two of the leading vaccine candidates are actually in the clinic with our adenovirus-based vaccines for SARS-CoV-2. So in, in the past, we had very limited options for what vaccines we can offer. Now we have multiple varieties of vaccines, and there are literally 160 or 170 preclinical different vaccines that are now being investigated. A good number of them actually went into phase 1 trials, and I'm going to discuss this in this slide. Usually, I put this slide, which came from Florian Kramer's lab in Mount Sinai, is actually I put this slide back in May. And usually it's a long road to get a vaccine, but as I'm going to discuss in the next slide, this has been shortened really a lot by this pandemic, which is something unprecedented in our human history, actually. So this is a cartoon representing the SARS-CoV-2 virus. This is basically the main protein that I'm going to discuss, but it's good for you to introduce you to that. This is called the spike of the virus. This is the reason why it's called coronavirus, actually, because it looks like a crown on the surface of the virus. And this is the protein that actually mediates the virus entry to our epithelial cells, and that's how the infection starts. So obviously, and again, I'm going to discuss this in a few slides, this is the most important target for us to actually, if we want to block the infection. If we basically target this virus by antibodies, we can actually neutralize the virus. But usually vaccines go through a lot of processes. Even if you get RNA vaccine, which is mainly RNA expressing this part, you don't express the whole virus, or the whole virus proteins, you express a protein. You pick one protein from the virus and express that and put it in the form of an RNA, which is a genetic material that you can inject in people, and they start making the protein itself. And our immune system will identify that as a foreign protein and start making antibodies against it. And once you have the antibodies, you are basically immunized. You can do the same thing with the DNA instead of RNA, or you can express the whole protein and then give it to people. And the other thing is you can take the genetic material encoding for this protein and put it in an adenovirus and then give the adenovirus to people. So there are multiple ways. Usually it takes a long time from the start to the finish. And just to give you an example, traditionally, if you are going to traditional way, if you start from a vaccine done in experiments in small animal models first, and then it takes years to develop usually these vaccine candidates. It takes years to take it through human studies, phase 1, phase 2, phase 3. And this is lots of clinical trials with a lot of specifications. But then you start applying for an FDA, and now you get and after that, after the approval, you start making the production. On average, anyone, if you get a vaccine from start to finish in 15 years, that's great. Obviously, everything changed with COVID-19. And you probably heard about that we are really, a lot of these usually long period, long requirements or long list of requirements are being cut short. And some of the phase 1 and phase 2 trials are combined. Even vaccines are getting into phase 3 before even the phase 1 and phase 2 results are in, which is something, again, unheard of. And the end result is we really could have a vaccine by the end of the year, which is, as I said, unprecedented, basically. To be able to start from February, March, and get a vaccine in November, December, that's really, and of course, at this stage, we are all at phase 3, and the leading candidates are at phase 3, which is basically the last point before going for the FDA and getting the license. And after that, it gets the large-scale production, which is companies are already starting to gear up for. So that's where we are at the moment, to make vaccines that can develop immunity against this part of the virus. But early intervention, this is something that we thought about in the lab, that you really need to have, vaccines takes time. I mean, 6 months ago, when we started working in the lab, we didn't realize that, we know that vaccines, it takes at least a few years. So we thought that we have to get something that can be helpful in the next few months. And the reason we think it's important to have this early intervention, because we know that once you have a certain virus load and infection, then there is a cascade of reaction that starts happening that it's very hard to stop at this stage, at certain stage. Once you have the virus replicate to a great extent and achieve this virus load in the lung, high virus load in the lung, all of the inflammation that follows can make it very hard to actually rescue the patient. And so it's very critical to start very early to eliminate the capacity of the virus or block the capacity of the virus to achieve this high load. So how you do that? So to understand how to do that, we have to really understand a couple of things. And I'm going to spend some time on this. So the first thing we need to understand how the virus actually entered the cell. And I talked a little bit about that, but just to get a little bit more detail. So as I said, the virus has this spike protein, a very prominent protein on the surface of the virus, that binds to ACE2, which is angiotensin converting enzyme 2, which it's a surface protein on our epithelial cells. And once the virus binds to this protein, and also we have some other helping protein that can help the virus bind and entry, the virus actually activates and start to a process called endocytosis, where the part of the membrane encloses the virus, and using some host protein, proteases to actually activate the virus. And the virus now inside these granules or endosomes, actually, inside the cell, the virus will release and start replicating. And once that virus starts replicating, the cell death has become the next step. And once you have a cell death, you start having all the inflammation association with cell death. Now imagine that's not a single virus, there are billions of viruses. So, and you have lots of, again, billions of cells, epithelial cells, and this is how the reaction starts. So how to control that? The best way to control that is to actually block this part, that entry part, because if you block entry part, the virus will not have a chance to increase in number, and you get from single virus to millions of viruses or billions, and those one will infect the neighboring cells, and that's the reaction starts. So to be able to do that, we know from excuse me, we know from our studies on the first SARS that this entry is mediated by a part called receptor binding domain, the RBD. I'll be referring to it as the RBD. It's a small piece, excuse me. It's a small piece at the tip of the spike protein, and it's very important for the binding to human ACE2. So how we can block this binding is by targeting the RBD and the spike by antibodies. And those antibodies can block this binding of the virus to its receptor, and that's how we protect the host cell. Okay, so and this is how actually all vaccines at the moment, all viral vaccines work. When you take your flu vaccine, this is what happens. You get the vaccine, you produce these antibodies, this time against another protein in the influenza virus, and we want to block the virus to bind to the epithelial cell. Same happens with most of other vaccines like tetanus. You get the vaccine, you get an antibodies against the toxin of the tetanus bacteria, and you neutralize the toxin, doesn't bind to its receptor, so you are good. So this is how our most successful vaccines against measles, against rubella, against yellow fever, against many viruses, all viruses basically. So, and against polio as well. So how we can do that and how this process work, and this is where really oversimplified way to go over this. So the way our immune system works to develop these antibodies is once you get exposed to either a virus infection or a vaccination, like the flu shot, you engage a subset of our immune cells called the B cells. And those B cells are basically specialized blood cells, white blood cells, to specialized to secrete antibodies that we want to protect. And the way, basically the reaction happens is like any chemical reaction, you give them the reactant, which is basically the antigen, what we call the antigen, which is the virus or the vaccine. And you engage these B cells, recognize that this is a foreign material in the human body or in the host body. And then once you have this recognition, you get the expansion, and some of these B cells differentiate, change actually into almost a factories of antibodies. And these factories, we call them plasmablasts. And those actually can even mature to what we also a factories of antibody, I mean factories of secreting antibodies to our plasma cells. So our goal from vaccines actually to get our B cells to differentiate to these antibody secreting factories, and also to differentiate to a memory cell that can remember that this molecule is foreign. So this is a very simplified way of looking at how usually vaccines work, or how our immune system recognizes viruses and vaccines. So if we can get these plasmablasts, we can actually use them, and if we can get the plasmablasts that respond to a particular infection, we can use that to learn from the genetic material inside these cells and make these antibodies ourselves in the lab. And this is what we do. So what we have been doing in our lab is actually, and this is something we have done with many infections, with influenza virus infections and with Ebola, with many virus infections, chikungunya, many of the different viruses that infect humans. Once you get infected, your immune system responds to that infection, and in blood we can identify these cells that respond to this infection. And if given that we know how these cells would look like in human blood, we can isolate them as a single individual cells and extract the genetic material from that cell that are responsible for secreting the antibody. But now we have these genetic material, we can secrete this, we can make this antibody in the lab. Now, instead of relying on that cell, now we have this knowledge, and we start amplifying these antibodies, and we can test their efficacy in animal models and then move them to the clinic. So once we know that those antibodies are specific against the virus because we only isolated them at the time of our immune system responding to the body. So the problem was in March that which is actually not a problem, is we were fortunate that in Missouri, we didn't actually have a lot of human infections. So we didn't have the starting material to actually make these antibodies. And again, it was a good problem to have because our neighbors, not really neighbors, but in the East and the West Coast, they did have a lot of infections, unfortunately, and they were actually having the material to do that, which is great. We did not. So what we did in the lab is actually went to the mouse. And mouse immune response is very similar, like many vertebrate immune response is the same. You give them a foreign protein, will do the same process that I discussed. B cells will get engaged and get differentiate to respond. The one thing that we can do with the mouse is we can control what to give it. We don't need to infect the mouse with the virus. We can just give it either the RBD, which is the receptor binding domain that I discussed, that's very important, or the whole spike protein. Inject the mouse with that, and the mouse will start the process for us, which is generating the B cells. And this is just data to show you that the mouse is indeed responding to, by binding in its blood by antibodies. So this is measuring of antibodies against the spike of the virus or against the RBD, which is the very important piece. And you can see that if you take the serum from those mice that injected with, can neutralize the virus. And this is the data support that. So what we did next is we took those cells, and I realized that this is not something that kind of data that majority of the audience is looking at. So I will just basically go over this very slowly and just tell you that this is basically, we're looking at B cells from the mouse, taking from the draining lymph node after immunization. So we immunize the mouse like in the muscle, like we immunize humans. But because mouse blood is not as, it's easier in the mouse to actually have access to the draining lymph node itself, where all the immune reaction happens. And then isolate these plasmablasts, the antibody secreting factories that I mentioned, and then take the genetic material from these cells, make them into the antibody that we can actually express in the lab. So we did this in March and April, and we generated 26 different antibodies, and they all recognize the RBD part of the virus, which is great. So this is just the data to show you that from those 26, we identified that 19 of them are totally different. Terms that they are coming from the genetic sequences are different for these antibodies. So it could be they are different functionally. So we took these antibodies, 19, and we moved to the next step. Are these antibodies, can they neutralize the virus? And that's the data that's showing that. Can these antibodies neutralize the virus? Some of them, as you can see here, is we are looking at the relative percentage of relative infection. So if you have nothing, if you have no antibodies in the system, and this is done with the real virus, a real SARS-CoV-2 virus, you have no neutralization. The virus, even regardless of the antibody concentration you add, the virus still replicates at 100%, meaning that this is really inefficient antibody. And if you look at some of the antibodies are weak, they don't neutralize the virus at low concentrations, but as you go higher concentration, they start neutralizing the virus. And this is typical. Some antibodies are weak. Some antibodies are a bit stronger, which is very good, that they are not neutralizing at very low concentration, but they are starting neutralizing at good concentrations. And you have 2BO4. 2BO4 was a very pleasant surprise to see. It's a very, very potent antibody that in that case, it's a monoclonal antibody that only recognizes one part coming from a single B cell at a very, very low concentration, neutralize the virus very efficiently. So you can see this is basically 1 nanogram per ml, and you get a really very or even less than 1 nanogram per ml. This is 10 nanogram per ml. But at 1 nanogram per ml, you get a very efficient, relatively efficient neutralization. This is really potent in terms of virus neutralization, because you can get way more concentration in our human body than this. So this is good news. I'm also showing here 2HO4, which is another antibody that I mentioned in a few slides, but I just wanted to show you that it's not as good as 2BO4, but it's actually still good. It can actually neutralize at reasonable concentration. So we have these two antibodies, and we know from our other studies, for example, 2BO4, why it is very efficient, because it's actually bind to the virus with a very high tight binding. And that makes it, and bind to the RBD of the spike protein in a very tight way. And that's basically data showing that this is very tight binding, and that is really a very good indication that this can be used in the clinic, because you don't need as much of the antibody, because it basically, if you're binding very tight and you have a very slow dissociation of the antibody from the target, then it's a very good chance that you can actually have a higher persistence of the antibody in the system, which is always a good lead for any drug in clinic, at least in antibody drugs. So the first thing we wanted to test is we want to go for the mice because this is the easiest system to test. So we went with the mouses, and this is done in Mike Diamond lab here at WashU, and we can actually injected the antibody 1 day before challenge with the virus. And then we looked by day 4, you have mice that have been injected with 2B04. They minimally lost weight compared to the mice that infected with the isotype control, which is irrelevant antibody that's of the same kind. Those antibodies these mice are starting losing weight very significantly. So this is a very good sign. And when we look at the virus titer, this is how much virus in the lung. You can see that why this is happening. This is in a log scale. This is more than 100-fold difference between the viruses that in the lung that compared. Actually, this would be below detection limit with the 2B04. So we basically, the mice that are injected with the 2B04 antibody were almost completely protected against this virus compared to the mice that infected with isotype. So again, this is consistent with the very potent neutralizing activity of 2B04. But then at the time, at the end of May, it came out that hamsters are a very good model for SARS-CoV-2 infection. And just to give you an idea, and I went through this quickly, mice, laboratory mice, the mice that we use in the lab do not express, or the ACE2 in the surface is not this, the murine ACE2 or the mouse ACE2 doesn't really recognize human coronaviruses or the SARS-CoV-2. So we had to artificially induce human ACE2 in these mice before we can challenge them with the virus. Otherwise, the virus will not replicate, and we won't be able to assess the efficacy of the antibodies. So it wasn't a direct way to achieve a challenge or achieve infection in the mouse. So when we saw that this article came out in May that Syrian hamsters or golden hamsters are actually, or both are actually good model for natural infection because they express, or their ACE2 is really recognized by the virus, so they have a productive infection without really any intervention. So you basically can put the virus or inject the virus, well, usually it's intranasal infection like what happens in humans, so you put the virus in the nostrils of the animal and you get infection right away. So because we wanted to make sure that before we move to the next step, that 2B04 is really protective in the best animal model, we actually tested that in hamsters. But also we did something different. We tested in 2 different ways. We either injected the antibody 1 day before you challenge, and this is what we call prophylactic treatment, or you injected 1 day after challenge, and this is a therapeutic treatment. Basically, you think of it as, if you take the antibody before, are you protected from infection in the future? Or if you're already infected and someone is already in the, 1 day after infection and the ICU starting to become symptomatic, can we actually, or sometime after infection, can we actually give the antibody and start controlling? And this is obviously a more challenging treatment in the therapeutic treatment. Prophylactic is usually giving the antibody the advantage to be there even before the virus introduced. And this is looking at weight loss over time of those hamsters. So if you give the hamsters the isotype control, they start losing weight. This is the original weight. They start losing. By day 7, they start now clear the virus. They survive, but they have they were really sick for a week. And then they start gaining weight. With 2B04 giving before challenge, the hamsters actually hardly lost any weight. And they maintained their weight, and then they started gaining weight, which is great. With the therapeutic treatment, which is, as I said, is more challenging because you are introducing the virus for a full day, allowing it to replicate, and now we put the antibody. We lost some weight in the beginning, but again, nothing compared to what we see in the isotype control, and we gain it very quickly. And this can be very easily explained by looking at the virus titer, the virus load, how much virus in the nasal turbinates, which is the upper respiratory tract in the animal, or in the lungs, which is the lower respiratory tract. And I just want you to focus on this day 2 after challenge. If you look, this is the control. This is if you give the antibody before prophylaxis, and therapeutic, which is 1 day. So you see that in both cases we decrease the virus titer compared to the control, both in the nasal turbinates, in the upper respiratory tract, and in the lower respiratory tract. So this is great, but one thing that we always worry about is that if you have a very potent antibody, the virus can escape. if there is too much pressure on that virus, it can make some mutations, and these RNA viruses are good at making mutations like influenza. So we thought we have to make an enforcement of that antibody. So we are going with 2B04, but we added 2H04, which is a different antibody that we decided that it has a good neutralization, and I showed you that in the curve few slides ago. And both of them, based on many of our studies, are actually showing that they are binding to the RBD in a different way. And this is the data showing that. And this is actually my last slide. So I'm going to tell you that based on our structure study done in David Fremont lab here at the WashU School of Medicine, we show that this is 2B04, this is the RBD of the virus, and this is 2H04. And it's clear from our other binding studies, but it's clear from here that those antibody bind to different parts of the RBD, which is, we are hoping, that means we are doing the experiments to confirm this. We are hoping that these two antibodies, when they used in combination, they will have a much better effect in basically additive effect in preventing virus or neutralizing the virus. And if you remember, yes, we do have other antibodies that maybe like this one is better than 2H04. We could have combined our best antibodies to these two antibodies, but they actually binding very closely together. So they are kind of interfering with each other. So we wanted something that they can complement each other, and that's where we are. So I mentioned in the beginning, we are very close. So we are actually at this stage, these antibodies came, as I discussed, from mice. And it's usually, you can use antibodies that came from mice, but again, our bodies will recognize that these as foreign proteins if you use them as drugs. So what we are doing at the moment is what we already done in collaboration with big pharmaceutical companies, is that actually we completely humanized these sequences, these antibodies, both 2B04 and 2H04, to make them look very similar to human antibodies. And there are lots of algorithms to do that. And this is something obviously can be done academically, but it's more efficiently done at the industry level. And now these antibodies are being produced to be tested by us to make sure that those are indeed in combination will be very efficient. And the next step is to actually develop those further and apply for the FDA to be them to use as therapeutic antibodies, which obviously will be a fantastic step for us, because we know that those are very potent in multiple animal models. We are doing even more experiments to see to actually assess the capacity of the virus to make escape mutants, especially if we used together. So this is where we are, and I hope I didn't really go so fast on some of those questions, or some of those points, but I'll be happy to take any questions about this part. And thank you.
Wonderful, thank you very much. There are lots of questions, so I want to start with just a bit of a clarifying question. So students are interested in the RBD, and specifically how that, like if you could go over that just a little bit more, and also then how the vaccines work in dealing with the RBD. Specifically, one question was about, do you have to have every RBD site bound to an antibody in order for this immune therapy to be effective?
Oh, that's a great question. Actually, as we see actually from the last slide, so as you can see here, this is the whole RBD as a protein. And this antibody is mainly this is the main point of contact, one amino acid here. And this antibody is 2B04. So it's clearly, if you can recognize only that part, you are able, that binding is enough for, as you saw, that enough to neutralize the virus. So it's very shown here in simple in the cartoon here that you really, and it's actually almost exactly works this way. If you have an antibody that can actually block that, conformationally block that part, you really have no ability of the virus. You have to cover a certain percentage of the RBDs of the whole virus, and this is not really hard by antibodies. If you inject it, that's why the higher the concentration of your antibodies, the better your chances in making sure that there's no infection happens. So this is, so you don't have to cover the whole RBD to be able to get neutralization, because we know that from the data we have, is you can recognize only at least one residue, and you still, as long as it's, you can actually block that binding, that's all what you want.
Perfect. Okay, great. That helps. And so then another question is, can you talk a little bit more about how, if we know that this is working in a non-human animal model, then how do we move that into making sure that it can work in a human model?
So that's the next step, is actually, these studies are the way you test that, and usually this is done in phase 3 studies. Once you make sure that it's safe as a drug, and antibodies have been used because the biologicals and different from chemicals and small molecules are very safe, because they are part of what we do make as protein. So the first part is, of course, you cross the safety part, and then you do what almost like a field trial. You go to an area where, in that case, you go to an area where the expected outbreak, or maybe a nursing homes, and you start injecting these antibodies and test the efficacy, basically, in a way that how decrease the attack rate in that place by these antibodies. So, or you can actually go to the ICU and have a trial with the emergency room, and say, if someone comes in very symptomatic, very confirmed COVID positive, let's inject the antibody right away and compare those to those that didn't get injection of the antibody, and see how, this is how you test, this is how you're going to test the vaccines actually. And right now in phase 3, right now we are trying to give the vaccines to 30,000 people as a phase 3 trial, but this is how you follow up those injected vaccinated people, and then see what's the attack rate in vaccinated versus non-vaccinated. This is how you test the efficacy. But you can do the same with monoclonals, although monoclonals, you probably do it in the set of a clinic, or emergency room, or probably as a nursing home, if you were thinking about prophylactic treatment.
Yeah, that's great. No, I think it's helpful for students to understand the process and how this goes.
So that's really a long process, yeah.
Yeah, that's helpful. I think that I'm sure that I am one of many people on this call who now have a new favorite letter number combination, which is 2B04. Oh. It sounds promising, so I'm excited about that. So when thinking about that, and you mentioned that RNA viruses can mutate and change, and other speakers have talked about that as well. So students are wondering, as we come up with these antibody responses and therapies, then how often will we need to change them in order to deal with any of those changes?
So that's a great question, actually. So far, we comparing this to something that I've been familiar with influenza, which is the challenge that I've been working on for all my career at this moment. We don't see nothing compared to influenza, to put it clearly, nothing compared to in terms of the rate of changing those epitopes. It seems that, yes, there are some small changes, but it's not affecting, you really need changes that completely abolish the binding of multiple antibodies to say, oh, this escape was going to make a huge problem on a public health level. But we are not seeing that so far. I think we are in a better shape compared to the case with influenza, which is really notorious in terms of changing its main antigenic determinants on the surface of the virus, and that's how we have to vaccinate every year. Again, as I said, as a precaution, I said this, we're still learning. Hopefully, so far the signs is we will not have the same problem as influenza, but who knows? We are still in the middle of the process.
Absolutely, yeah, and that's been something we've said a lot in this course, that we don't really know for sure yet, because we don't know that much about this virus yet. But in terms of just kind of generally these timelines, I mean, students were asking, why is it that some vaccines or immune therapy processes work for a long time? So for example, you're talking about the flu vaccine. That's something that you end up getting every year. You have things like tetanus, which I think is like every 10 years, and then things like polio, which is once in your lifetime. Why do we see different vaccines effective for different lengths of time?
So again, that's an excellent question. We have this is based on what we think is what we establish in the field as a correlative protection, which is something we don't have for COVID yet, obviously. A correlative protection is, can I measure something in your blood that can tell me, predict how protected or not you are? And that takes time to establish that correlative protection. It takes a lot of studies over the years to say, for example, if your level of anti-influenza antibodies in your blood is X, uh, or above X, you are protected. So based on that, we think, okay, for tetanus, we based on the established correlative protection in serum antibodies against the toxoid of tetanus, we see that you don't need any vaccination except every 20 years on average. Actually, some studies are now saying that even 10 years can be longer, can be 15, because people are still, or that correlative protection is probably very stringent. Maybe it's actually better than that. Some viruses never change, like measles or polio. So, and your antibodies that you generate after the first exposure are enough to protect you forever. That's great. Um, for influenza, we know that that correlative protection is decreased within after 6 months of vaccination. And this is something that active area of research, why this happens and all of that. But that's why we recommend the annual vaccination in addition to the virus itself is changing. So that correlative protection is a huge problem that we don't have because you have to establish this over multi-year studies, and we don't have it for COVID yet. We don't know what really exactly the level, and it helps a lot to assess the vaccine effectiveness and all these downstream recommendations. And this will be something will be obviously a subject of research for the next many, many years.
Yes, for sure. Well, that's helpful. And I think another form of treatment that students have heard about in the news, and that I think what you're talking about is related to, so they'd like to get your opinion on it, is convalescent plasma treatment. Yeah. This is something that students have been hearing about. So given what they've learned in your lecture, can you explain a little more about that?
Yeah, it's a great one. One of the slides that I thought the time I removed for the sake of time, but it's actually, this is one of the oldest way of treating virus infections. Not only virus, actually started with bacterial infections in the early 1900s. It's used to be the serum therapy. It's basically, if you don't have access to what I just described to you, is let's go for the people that recovered from infection, and because they went through the process that I discussed with you here, they went through this whole process. And now they have these antibody secreting factories that not only generated the antibody, but they have those what we call permanent cells that secrete antibodies for their lifetime. And these antibodies are poured in their serum to protect them. So now we can make use of that. It's obviously not ideal for many reasons because everyone will have a different, it's a great emergency intervention. Because you have nothing else if you don't have any characterized antibodies, monoclonal antibodies to intervene with. You can use the serum, and then it's obviously various efficacy because some people, not everyone will respond in the same potency. So what you get is a variation in our immune response, and also a variation in the quality of the antibody. Not everyone would recognize the RBD. Or recognize that not all the antibodies in your serum will be like 2B04. Actually, most likely you will have a mix of antibodies. Most of them will be like this, non-neutralizing at all. Some of them are very weak, majority of them are very weak, and very few are 2B04-like antibodies. So basically, when you give serum, you give a mix of everything. And yes, you could be lucky and you have way more of that than this, but it's this uncertainty. It's definitely better than nothing. That's for sure, or at least, well, we think it hasn't. The studies have been done really nicely. It wasn't really well-controlled studies, but we have an authorization to use that at the moment, FDA authorization.
Yep, absolutely. Okay, great. So then, related to that, also, students are wondering, how long does immunity last? I mean, we've been hearing, about how even people who have recovered from COVID-19 maybe don't maintain immunity. And then what does that mean for these immune therapy plans?
Yeah, so in general, in an acute virus infection, immunity basically lasts forever. And that has been the case with measles, which is a live attenuated vaccine. I'm assuming most of our students here have got the MMR vaccination, and that MMR vaccination has lasted them, will last them forever. And the reason forever is because of these cells that are in the bone marrow that keep secreting these antibodies. So at the moment, we don't know. Uh, there is really, we cannot tell how long this immunity will last. We know that once you get infected with COVID, there is very few in the last 2 weeks, very few cases of documented reinfection. And we are talking about 25 million confirmed infection. And when we are talking about really few cases of documented reinfection, we still have, I think the principle still stands that if you get infected, you are immune for the period of time that we think it's at least a few years, a couple of years, that till we be able to establish what's the correlate of protection, which is when is your level, if your serum level, the antibody level decreases beyond the or below a certain threshold, you are now susceptible. So to answer the question again, I don't know how long. I just think that it should definitely not less than 6 months. If any virus related to the virus a person infected with, by all immunological principles, you shouldn't be infected again with anything related in the next 6 months or a year.
Okay, that's good.
We'll see what happens as we move on.
Yeah, absolutely. Okay, so then also you showed us how a vaccine is really, I mean, throughout history, this has been a game changer for different viruses. And so when thinking about this particular vaccine, you also showed us how normally 15 years is a triumph in the vaccine world, and we're looking at getting a vaccine in 8 months. So students are wondering, like, why can the timeline be shortened so much for this particular vaccine, and can it actually safely, or do we have to worry about the safety of it?
Okay, that's a great point. And again, I'm not sure if I'm the best person to answer this. I guess I'm not really an epidemiologist, and I can tell you one thing is the 15 years here is because there's no urgency. For example, if people looking at developing new vaccines against uh, chikungunya virus or dengue virus or viruses that are not causing an immediate issue, there are a lot of things that goes inside this process, not only the science, which is making the vaccine in academic lab, which if in that case, if you have a pandemic, the first vaccine candidate literally was in the first few weeks. But usually this doesn't happen. It takes years and years of research and trying to optimize. We don't have that, right? So that's the first cut in the time frame. But also think about, companies usually spend a lot of time. You have to have an industry partner to be able to get the vaccine on that large scale. But if you have a pandemic, like in this case, companies are really lowering the threshold to do, basically for them, any investment is a risk. And for them is, with the case of the pandemic, they really remove these thresholds and they are going in with everything. So that we don't have that hesitancy. It's just everything is being went all the way, generate a material that can be in clinical trials, start clinical trials, start investment. Also, the government's putting a lot of money in that. So these are a lot of things that usually takes a long time, long time in studying and assessing the risk and going into that. Do we have the market? Do we have all of that? Economically, is that a viable thing? It's a lot of these things that are not in play at this moment, and that decreased the time. But obviously, a lot of also the FDA actually are really relaxing some of the requirements. And I said, I don't know how, if this is will increase our risk. I'm on the optimistic side. I think hopefully it won't increase our risk. But I think I would leave this for someone more in this field. I'm really into in this part, in the testing and making the vaccine, but really you need more someone on the epidemiology side who can tell you more about the increased risk.
Yeah, no, I think that's completely fair. And I think that what you've shown us here is so great and adds a lot of hope, because it's nice to see clearly a walkthrough of the process of dealing with this virus and how it is actually possible for our medical community to find ways to deal with it so that we can all hopefully get out of this pandemic soon. So thank you very much for taking the time to talk to us. This has been really wonderful. I really appreciate it.
Oh, thank you. And thanks for all the wonderful, great questions. And I really appreciate that.
Absolutely.
Thanks for having me.
Yes, thank you for being here. So it's now going on 2 o'clock. So we are going to shift over to our second presentation of the day. So we have 2 people for our second presentation. It will be by Jaszmine Parks and Phoenix Lintner from Safe Connections, which is a St. Louis nonprofit that reduces the impact and incidence of domestic and sexual violence through youth education, 24-hour crisis care and therapy for adult and teen survivors. They will be discussing intimate partner violence and safety during COVID lockdowns. Welcome, Jaszmine and Phoenix.
Thank you for having us. All right, I'm going to get started sharing my screen. Okay.
While you're doing that, I'm just going to ask Phoenix to say hi to the class so we can see her. We come on screen when we talk.
Oh, gotcha. Hey, I'm Phoenix. I'm from Safe Connections. Yeah.
Thank you.
All right, everyone. So we're going to go ahead and jump right into things. There it is. So today we're going to be talking about COVID-19 and its impact on intimate partner violence. This is going to be an introductory lesson on how it's impacting intimate partner violence. This could honestly be a course in and of itself. So we're going to try to condense things down. If there are going to be a couple of points where we can pause and ask for questions like clarification, can you explain that point again? But the majority of time for questions is going to come at the very end. So my name is Jaszmine Parks. I use she, her pronouns, and I'm the Crisis and Community Education Manager with Safe Connections.
Hi, I'm Phoenix Lintner. I use she, her pronouns, and I'm the COVID-19 crisis counselor at Safe Connections. So I'm going to talk just a little bit about what Safe Connections does. Our goal and mission is to reduce the impact and incidence of relationship violence and sexual assault through education, intervention, crisis intervention, counseling, and support services. So we have a variety of different services. The biggest one is the 24-hour crisis helpline. It has been in place for 40+ years. You can call any time of day or night when you're in crisis, and someone will be there to listen and support. We also have individual counseling and group therapy for teens and adults who are survivors of domestic and sexual violence, as well as teens who are getting bullied due to gender presentation and sexual orientation in school. We also have what we call Project Heart. That is a community prevention education and training type of thing. We go around to schools, to group homes. We teach folks about healthy relationships. We also have what we call groups. They're a smaller atmosphere with somewhere between 12 to 20 students picked from a certain school. The goal is to change the culture of the school to aim towards healthy relationships. All of our services are free. We serve all genders, anyone 12+, and they're there as long as you need them.
All right, so to start things off, we're going to try to explain the scope of intimate partner violence and nail down one particular definition for our purposes here. So I want us to think about, who is being affected by intimate partner violence, or some folks call it domestic violence. Honestly, everybody is being affected by it, whether or not you are a primary survivor of intimate partner violence or a secondary survivor. So of our entire population, women aged 16 to 24 tend to experience the highest rates of violence, right? But individuals of all gender identities, expressions, sexual orientations experience intimate partner violence. And there is conflicting reports, and I think this is due to the fact that intimate partner violence is a chronically underreported crime, right? There's conflicting reports about whether or not LGBTQ folks actually experience a higher rate of violence than maybe cisgender folks or folks in heteronormative relationships. So all of that population of folks who are experiencing violence in their relationships, 70% of those folks did not realize that they were in an abusive relationship at the time, right? That is an incredible number. So if we know that 70% of folks are having a hard time even identifying it, Of those folks who could identify it, 60% said no one stepped in to try to help them, right? And 42% of folks decided to keep that to themselves and didn't want to share it with other folks. And there's a lot of reasons to that, and we're going to go into that for a second. But I really want us to keep this in the back of our mind when we're thinking about the scope of this issue and how often we really don't talk about it.
Okay, this is our first question, but I wanted to give you all a reminder that we will be discussing intimate partner violence and sexual violence. We talk about these topics all day, every day, and we recognize that you may not necessarily go through this and talk about this every day. There could be survivors in the room, I'm not sure. Please do whatever you need to do to take care of yourself. Doodle, leave the room, do whatever you need. So our first question is, if I ask you to imagine what intimate partner violence looks like, what picture comes to mind?
Feel free to chat in the Q&A box very quickly if you can think of movies, actions, words, right? What kind of picture comes to mind? Who's a typical survivor? Who's a typical abusive partner? And it's okay if you're like, oh, this doesn't feel right, that's okay. Just let us know anyway.
Okay, so I see some people answering some stuff.
Okay, really great examples. All right.
Do you want me to read off some of the answers?
Oh yeah,
that
absolutely.
would be excellent. Thank you.
Yeah. So I'm seeing things like gaslighting, power dynamics, one partner hitting another, rape.
Absolutely. Fantastic, everyone. Thank you. So yeah, I mean, when we think about what intimate partner violence is, there's this huge, it's almost an umbrella term for a lot of different actions, and we want to kind of focus on the motives behind it.
So a good definition we use is a variety of abusive behaviors or seemingly sporadic incidents of violence that one person uses against their intimate partner to isolate, intimidate, instill fear, and decrease a partner's self-esteem and self-worth. You know, a lot of times people think of intimate partner violence as just being physical violence, but there's so much more to it.
Absolutely. So some of you all may have seen this before. I think if you've ever worked in the intimate partner violence field, sexual violence field, you've probably seen this. This is the power and control wheel. It was developed a few years ago by some domestic violence intervention programs in Duluth, Minnesota. But this is a fantastic visual representation of what intimate partner violence looks like. So on that outer ring, we see things like physical violence, sexual violence, and it's on the outside because those are the things that we socially have come to recognize and accept. Yes, this is intimate partner violence. This is sexual violence. And importantly, this is what generally our legal system understands as being intimate partner violence or sexual violence, right? But then if we move closer in, we see all of these different sort of pie pieces, and these are also examples of intimate partner violence that don't really require anyone to lift a finger. And in my work working with survivors, working in domestic violence shelters, I've heard time and time again that the physical violence was one thing, right? Those physical scars healed, but things like emotional scars, right? Trying to get back together financially, those are the things that are hardest to overcome. And that's partly because we don't really recognize that as intimate partner violence. So we'll see things like emotional abuse, right? Using isolation, minimizing, denying, blaming, using male privilege. I would throw in there using straight privilege, right? Using cisgender privilege. All this goes into it. So, well, again, we could spend the entire time talking about all of these. We're just going to zoom in a little bit and focus in on emotional abuse right there on the right-hand side. So somebody mentioned gaslighting earlier today, and I'm so glad that you brought that up because gaslighting, like I said before, is one of the most difficult things to overcome for a survivor. So for those of you that maybe don't have a very clear definition on gaslighting, that's really when somebody is breaking down a survivor's confidence, right, or their trust in their own sanity by constantly questioning a survivor's reality, questioning their recollection of events, questioning their motives, things like that. And can you think about how damaging that is if somebody keeps telling you over and over and over again, like, I don't think you understand reality, right? No, you didn't remember that correctly. That kind of shakes your whole foundation, right? If I can't even trust what I'm seeing or what I'm feeling, right, that's incredibly damaging. And I also want to throw guilting in there because it goes hand in hand with gaslighting. So guilting can also force a survivor to maybe second guess their own moral compass, right? And again, that is such a fundamental thing to how we view the world, how we interact with others, the choices we make every day. So that really knocks somebody off balance. And those two kind of go together a lot. So some scenarios I've seen or heard about over and over is maybe an abusive partner humiliates, maybe physically abuses their partner or something like that. And the survivor, right, has a natural reaction to that. So they say, hey, you can't do that to me. If it's physical abuse, maybe they lash out, they defend themselves, right? And what happens is the abusive partner can kind of twist the situation and say, ow, like you hurt me for having that reaction. How could you do that to me? How could you hit me? You know, how could you tell me to stop? How could you do that to me? Ah, you hurt me. And then sometimes the survivor finds themselves apologizing for having been abused in the first place, right? And think about how confusing and how twisted that is in your mind. And that can be really hard to overcome even with therapy, right? So I encourage everybody on your own time to just quickly Google the power and control wheel and become familiar with these, because these are very subtle tactics that can be incredibly powerful in an abusive relationship.
So these are some of the long-term effects of IPV on a person: PTSD, depression, anxiety and mood disorders, deliberate self-harm, suicidality, I'm horrible at saying that word, eating disorders, substance use and abuse, insomnia, nightmares, and other sleep disturbances. So all of these are things that will happen even if there's no physical abuse. And in fact, that abuse is really likely to cause that stuff. This is something that will make it difficult to overcome an abusive relationship. In other times, it can empower someone to kind of take steps to get help.
Right. And let's think about how difficult it can make, maybe take depression or anxiety, mood disorder. It's like Phoenix said, can you imagine trying to just battle that and get out of bed, right? Just to function day to day, but now trying to leave an entire relationship. If you build a home with somebody, if you've got kids in common, right? This is something that's incredibly difficult to overcome. And again, something I encourage folks to kind of keep in mind if they're thinking about, oh, well, I may have a friend, I may know somebody, or maybe this is happening to me. These can be signs that somebody is in an abusive relationship or in general just needs help, right? All right, so we're going to pause just for a second to see, does anybody have any clarifying questions? Are they confused about what gaslighting is, guilting, or if there's something we said?
So some students have questions about the difference between intimate partner violence and domestic violence. And there are a few others also, but let's start with that one maybe.
Yeah, you know, intimate partner violence is really just an expanded definition of domestic violence, right? It's just trying to take into account that not everyone who's in an intimate relationship is domestic together, right? They don't necessarily live together, right? They may live separately but are still experiencing violence. So it's kind of expanding that definition, but a lot of folks will use it interchangeably.
Students are also wondering if you could talk a little more about gaslighting, like how is gaslighting different than teasing, for example?
Oh, yeah.
Okay. Gaslighting, I primarily work with high schoolers, and I see that quite a bit. The whole thing about gaslighting is that it really makes the person feel like, well, maybe I did misremember things. Maybe I'm the problem. What we see a lot, especially at younger ages, is someone will have a reaction to something, and then the other person will say, well, you're too sensitive. You just take things too seriously. I mean, think about that. Someone is hurting you and then telling you you're too sensitive and that's why you're hurt. It's just, it's really, really bad. Teasing is more like, okay, I'm going to joke about this or that, you know, make fun of you because you're short or because you're whatever, you're really into cats, whatever. Gaslighting is more, it's aimed at breaking the person down.
Yeah, it's the intent that's at the heart of it. Mm-hmm.
Okay, and then related to the definition of intimate partner violence, what is the difference between a secondary or a primary relationship?
Yeah, absolutely. So I think there's probably more research and literature on it for sexual violence. I know the YWCA is a national organization. They've got a chapter here, and they provide counseling to both sort of primary and secondary victims. So those primary folks are the folks that maybe have been assaulted themselves, right? These are the people that experience the trauma, right? They experience the abuse and things like that. The secondary group is for folks like partners of those people, friends and family members of those people that are now trying to support the survivor, but maybe are finding that it's triggering their own memories, are finding themselves emotionally exhausted, right? With a partner, especially an intimate partner, maybe they're finding that their intimate relationship has changed, right? This isn't the person I was dating before this incident happened. And so there are these, almost think about dropping a pebble into the middle of a lake, right? There's that initial pop up and the ripple, but those ripples keep going out, right? And everybody's sort of affected by it. I hope that answers that.
Yeah, that's helpful. So just one more clarifying question. And I also myself would like to clarify one thing, which is that as was already said in this presentation, if you are feeling triggered in any way by this presentation, as your professor, I am telling you, you are welcome to step away and there will be no repercussions for that. So please feel free to do so if you need to. So the last clarifying question for right now for the two of you is knowing how to refer to someone. How do you know whether to use the term survivor or victim?
Phoenix, what do you think about this one?
I know that everyone uses a different term. I use the term survivor because when someone is a victim, in a way, it feels like it kind of disempowers them and makes it seem like they can't do anything to help themselves. Whereas survivor is more like someone who recognizes this is a problem, that this is an issue, and they're going to take the steps that they need to get out of this toxic situation.
Absolutely. So I think if somebody explicitly says I'm a victim, they choose to use those words for themselves, of course, please honor it. But we'll talk a little bit about empowerment advocacy towards the end, and survivor can just be a bit more empowering. All right.
All right. So the whole motive, the whole reason why someone is doing these is all about power and control. Unfortunately, what I hear a lot of people say is stuff like, well, this person has an anger issue. They have a temper. They had a bad day at work. They have a drinking problem. And while all of those things may be true, the whole point behind abusing someone is actually power and control. Even if they weren't drinking, they'd still be abusive. Even if they didn't have a bad day, they would be abusive. They'd make up an excuse for it, but the whole point of it is behind the power and control. When you look back at the wheel, you'll recognize that at the center of all of those abusive behaviors, it's all about that power and control. That person wants power and control, and they're going to do whatever it takes to get it.
Absolutely. And I think sometimes it can be kind of difficult to wrap our minds around that, because oftentimes an abusive partner is still a partner, right? It's still somebody that often will show us love and show us care and moments, things like that. So sometimes, instead of thinking of them as, you know, an abusive person as this like giant hulking shadowy figure that is driving for power and control, maybe we can think about it more like a value system, you know. And I'm glad that Phoenix referred back to that power and control wheel, because the center of that didn't say, you know, love and affection or, you know, a bad day, substance abuse. It's really about the fact that an abusive partner, for whatever reason, when they're in a relationship, they desire to control their partner, right? They feel more secure if they can tell the partner what to do, how to do it, when to do it, right? They value control over other folks, right? That's what it's about. And so that can help us think about, can I talk somebody out of it? Can you have a conversation and change somebody's fundamental value system? Probably not, right? And keeping in mind power and control can kind of make it a little bit easier to recognize when you're in an abusive relationship. So I always like to tell folks that relationships exist on spectrums. They don't live in boxes, right? There are no, there's sometimes, I will say no with an asterisk, there's rarely ever a box that you can check, or 3 or more boxes, yes, this is an abusive relationship now, right? Relationships come with highs and lows, right? They flex on this system of healthy to unhealthy all the time. Certain actions will push them to healthy, certain actions will push them to unhealthy or abusive, right? And so we have to keep in mind power and control if we're really trying to identify it. So I'll take an example of potential financial abuse, right? say we have two couples, and in couple one, what partner A tells partner B, I demand that you deposit all of your checks into my bank account, and I will pay for all the bills, I'll handle all the finances, and if I feel like it, I'm going to give you an allowance. Don't ask me about it, don't tell me anything about it, I'm in control here, right? In part, say couple two, right? Totally different scenario, but maybe somebody's like, you know what? I am terrible with money. So if it's okay with you, partner, I'm just going to deposit my checks into your bank account. You give me an allowance. I can spend it however I want. I don't want to think about bills and things like that. You'd handle it for me, right? Those are the exact same actions, right? So we can't really check off that action and say, yes, this is abusive. We kind of have to think about the motivations behind it, right? Is this somebody who is consenting for this to happen, or was it somebody demanding that they could do it so they have control over their partner, right? And I also want us to think about, people are very complicated, right? If we know that relationships exist on spectrums, maybe instead of asking folks, are you in an abusive relationship, or telling them you're in an abusive relationship, maybe we can start saying, are you in a healthy relationship, right? Do you feel valued and appreciated in this relationship? Because they don't have to be abusive, right, to not be healthy, right? And honestly, abuse can make it very difficult to understand what's going on.
So one of the questions that we hear all the time is, why don't they just leave? It's so much more complicated than that. I'm going to ask you all in the Q&A box, just put some reasons why you think somebody would not leave an unhealthy or abusive relationship.
So they're saying things like kids, financial dependency, fear of retaliation, the idea that someone will change, or because you love that person, you might have nowhere to go. Sorry.
I think, oh, that's okay. I just wanted to say that fear of retaliation is a big one. I think a lot of times humans think, oh, if this person just leaves, everything is going to get better. One thing that we know is that when somebody is leaving an abusive relationship, that is actually the most dangerous time for them, because that abuser has power and control over them. And once that power and control gets taken away, that abuser is going to do whatever it takes to get it back. They will attack the person, they will attack their family, they will attack their friends, their workplace, whatever it takes to get that back. I like that you also, folks also mention kids. That's a really, really big deal. It's a lot harder than it sounds to just pick up your kids and move somewhere. Money is a big thing. And of course, this pandemic is making things much, much more difficult for folks.
Yeah, if we can think about like how many of us could decide today that they were going to completely start over their life and it would be totally breeze. I can't do that, and,
No.
Right? So we just have to have a little bit of patience for folks. And I really love somebody saying that sometimes they love them. That's something that we don't really talk about often. And Phoenix has this fantastic wave analogy that I'm going to let her talk about, but it really gets at that idea of still loving your partner.
So a lot of times people feel like, okay, well, if it's so bad, I wouldn't stick around. But the thing is that it's not always bad. It's like standing by the edge of the ocean and you have all these different waves come in. You have a wave come in where they're loving and kind and they bring you flowers for no reason whatsoever. Or they cook dinner, your favorite dinner, and clean up afterwards. Or they take you away on a romantic getaway. But then you also have waves where they come home and yell at you or throw things around or, spend all your money on, I don't know, Legos or something, whatever it is that people buy. And the thing is that when someone's in that relationship, you don't know what kind of wave is coming in. One will be bad, the next 5 will be good. And so that makes it a lot more difficult. And it makes it a lot easier to kind of explain away the abusive actions. Because yes, they may have done something that was awful and mean to the person, but then for the next 2 to 3 weeks, they are kind and loving and just the most perfect partner in the world. And it's a beautiful sunny day the whole time. So that the waves of what's happening make it so much more difficult.
Yeah. So when we're talking about difficulties, I want us to all kind of take a look at this and try to hold this in our head. because in a second, we're going to talk about how COVID-19 has exacerbated these already existing barriers. So distrust of authority or law enforcement is one of the main things that I hear. So if we think about what's going on outside of our pandemic, right, when we think about the protests that's going on, right, not every community feels comfortable going to law enforcement. And there are survivors that maybe do come from a community that's historically okay with law enforcement, but they had one bad interaction, right? So maybe there was an incident, they called the police, and the police said, y'all just figure it out. This is a he said, she said, I'm not doing anything about it. Oh, you crazy kids, you know, I'm leaving, right? Or they show up on the scene, they say, you both are the same gender, right? That's no way. Or you're physically bigger than your partner. What do you mean they're abusing you? Nope, I'm leaving, right? And we see that happening all the time. There can be a lack of knowledge about available resources. So how many people know offhand how many domestic violence shelters exist in the state of Missouri, right? How many people know that there are legal advocates that will go with you to maybe your court hearings, your divorce hearing, your child custody hearing, your order of protection hearing, right? That's not something that people know about. And so there's a lot of supports out there that are just inaccessible for a lot of people. And then socially, if we think about mixed messages about healthy relationships, right? When I'm like driving around, you know, and I'm dancing to music and stuff like that, and I stop and I listen to the lyrics and they're talking about being super jealous and like, my girl, you can never go away. I'm like, oh, like I want to love this, and I do, but also this message is super unhealthy, right? And there's also a constant pressure to be in an intimate relationship in the first place. Depending on the culture that you're from, that can be even bigger than maybe some of us American-born folks, right? Those of us who've been socialized as women, a lot of times we hear, and this is for everybody really, but can't wait till you find your other half. You know what I mean? You are not complete, you're not a whole person until you got your other half, right? And so maybe if you do find somebody and you introduce them to your family and they're great, and suddenly you realize, ooh, they're not so great, but I need to be in a relationship and my family loves them, and oh gosh, I think I have to stay, right? There can be a confusion of legal rights, especially if we're talking about on undocumented folks. Am I still able to go to the courts and file for an order of protection, right? There's a lack of confidentiality, right? There's a lot of feelings of shame, anxiousness, depression, isolation, and we kind of talked about it earlier. There's a lot of shame associated with being in an abusive relationship in the first place, right? Despite the fact that a lot of us experience it, and every gender, every sexual orientation will experience it or has a chance of experiencing it, it's still kind of swept under the rug socially, right? And oftentimes, especially in smaller cultural groups, LGBT groups, right, we'll share close social groups with our abusive partner. And so sometimes we don't want to leave and lose a friend group, or we don't want to out them as a bad partner to our friend group, right? And again, if we care about that person, not every survivor is like, yeah, I just want to ruin their life. You know, I want them to have nothing to come back to. No, we still want to be good people, right? So all of these are barriers that are always exacerbated by the pandemic.
I would also add that in a lot of those smaller communities, there's a lot of pressure not to report them. You know, I hear this a lot with the queer community. You know, everyone wants to put on a certain face. We don't want folks to think less of us. And so there's a lot of pressure to just let it go, pretend like nothing happened.
Right. So if we're looking at law enforcement, available resources, mixed messages, things like that, I want to ask everybody, in a second, we'll ask how COVID-19 has affected this, but does anybody have any questions? I'm going to go back to the previous slide just in case. Have any points of clarification?
I guess a few questions that might help to kind of clarify is students are trying to I think, understand what does constitute an abusive relationship, and you know, the difference between unhealthy, you know, and maybe having a relationship that oscillates between healthy and unhealthy, not abusive, but healthy and unhealthy versus abusive. And also if an abusive relationship can become better, or if an abusive partner can stop being abusive.
So one thing I will say, because I hear a lot of people have confusion around what's unhealthy and what's abusive. For me, it's all about the power. You know, in an unhealthy relationship, both people are hitting each other. Both people are yelling at each other, treating each other badly, you know, gaslighting each other. But in like a badly abusive relationship, only one person's doing that. The other person may be doing something to try to retaliate and try to gain that power back. But in an abusive relationship, one person is holding all of that power and control.
Yeah, absolutely. And so I would say the difference between maybe just an unhealthy relationship, and again, this is such a gray area, it can kind of bleed one area to the next, but the difference a lot of times between this unhealthy relationship and an abusive relationship, maybe you can think about it in terms of like agency. So in an unhealthy relationship, maybe it will feel like, I don't really feel valued here. I don't really feel appreciated. I think talks over me sometimes. I think she calls me names, things like that. In an abusive relationship, there's a lot more fear there. So in an abusive relationship, it might feel like I am unworthy, right? I am dumb. I have learned from this person that I better not speak up, otherwise there's going to be serious consequences, right? If maybe you notice, if I get that look from that partner, I know that there's going to be some issues, right? That's how you know that there's been a pattern identified, right? There's certain tactics that have been employed over and over and over to the point where the survivor is kind of, I don't want to say learning how to behave, right? But it's feeling like they might be in fear of danger, right? Maybe not just physical danger, but that ability to say, oh my goodness, if I do X, Y, and Z, there's going to be so much with it. I'm walking on eggshells. Oh my gosh, I can't do that at all. That's what's pushing it into the abusive relationship, right? It's not so much that general feeling of I'm not comfortable in it. It's that I know something bad is going to happen. I'm walking on eggshells. I can't speak up. I don't have control here. And if I try to get it, there's going to be some issues. I hope that helps.
Yeah, can I ask one more clarifying one that I'm seeing in the questions? You mentioned, you used the phrase socialized as a woman, and can you just clarify that phrase?
Yeah, absolutely. So I say socialized as a woman instead of maybe being a woman, right? Because there are some of us who have been born and raised based on our gender assigned at birth, raised as a particular gender, and we find out that that is not our gender, right? So I say socialize as a woman because that's how we were raised, and to acknowledge that those who are maybe socialized as men are taught a different set of values. They're taught to aspire to something different than those who are raised as women, right? And so there is historically just a bigger pressure on those who've been raised as women to, on average, this is not the same for everybody, right? But on average, those folks who are socialized as women have a bit more pressure to be in relationships, start the family, be the glue that holds that family together. Whereas those raised as men maybe have a little bit more leniency. Okay, so we're gonna power on that. Take a look at all the slides, wave as they go by. Okay, so I'm gonna stop here for a second. Take a good look at this list again. Think about law enforcement, available resources, healthy relationships, right? Feelings of anxiousness, depression, isolation. Okay. How do we think COVID is impacting those things? How do we think COVID-19 has impacted maybe how law enforcement is going about addressing things? How do we think it's impacted survivors' mental health, right? And we, again, please type in the Q&A box. What do you think it's changing?
I'm seeing a lot of things like feeling trapped or lack of an exit plan. Students are asking if the police have good protocols for dealing with intimate partner violence. The fact that it's harder to get resources, helplines and the police aren't at full capacity, so there's a slower response time. Yeah, a lot, so many, just limited access to everything, basically, counseling, outside help, you know, all of those support networks that you're told to create and draw upon if you are in these sorts of situations that just have been cut off.
Most definitely. You know, Paul, law enforcement response has changed. Quite frankly, they may not feel comfortable going to a lot of places, and they're not necessarily enforcing certain things. The other thing is that they are still doing orders of protection in the courts, but the actual courthouse is closed. So all of these hearings have to be done virtually. Something that we're also seeing is folks who are wanting to file for an order of protection. The police are overloaded with other things, so they are unable to go and serve that filing. So survivors are having to pay a filing fee to pay for a process server, which, you know, 40, 50 bucks, really, that's a pretty big chunk of money. Lack of knowledge about available resources. Some shelters are letting people in, some are not. Some places are open, some are not. We see a lot of folks that are sheltering in not the safest place. You know, they feel scared to go to a shelter, which is understandable during this. So they're staying with relatives where they may not necessarily be as safe. Fear of going to the hospital for obvious reasons. It's also kind of creating a new set of tools for abusive partners. One of the big ones that we have heard about is the abuser will call, like DFS, they'll call the state and say, oh, well, my partner is exposing the kids to COVID. They have COVID and they are exposing the kids to it to make them sick. And so in that situation, the person who's going to get in trouble is the victim, the survivor. So there is kind of a new set of tools. We're also seeing situations where abusers will, you know, say, well, I'm sick and I'm going to come in here and take my mask off and there's nothing you can do about it. I'm going to go out and do whatever I want with whoever I want, and maybe I'll get it and I'll bring it home and you can't do anything about it. They're really using it as a point of manipulation. It's also difficult because there's a lot of folks that are out of work, that have been furloughed. And so a lot of folks that were dependent financially before are even more so now. There's lack of confidentiality in homes. You know, people know everyone's business. There's also a lot of mental stressors that have gotten worse. I don't know about y'all, but everyone I know is kind of on edge. And so folks who might have felt kind of in control of their own lives, now they feel the need to take control of someone else's. Folks where it may have been an unhealthy relationship, it could have tipped over into being a full-on abusive relationship. The other thing, and unfortunately this is kind of true for lots of folks, is that there's less access to supportive social networks. You know, some people are staying in pods like they're supposed to, but if you're only talking to the same 2 or 3 people, who are you going to tell if something starts going bad? You know, it also kind of leads into others not necessarily noticing, right? Like if your circle is small, that isolation is increased and folks are not able to see this is what's happening. It looks like you might be in an unhealthy situation. So it's a pretty significant change.
Absolutely. So we do want to leave a bit of time at the end to talk about any questions that you all might have. So briefly, we're going to touch on how to support a survivor. You do not have to be a paid professional like Phoenix and I are. You don't have to have a master's degree in X, Y, and Z to be a supportive person, right? If we remember the center of that power and control wheel of things, power and control, what is the exact opposite of that? It's empowerment and advocacy. If you don't remember anything else from this presentation, it all flies out of your head, please remember empowerment and advocacy, right? And there's 4 steps I recommend folks go through. The first one is, you know, if you've identified somebody as in a potentially abusive relationship, take a second to stop and think about what your own biases may be, right? And then focus on the survivor in everything that you do. So this looks like, even if a survivor comes to you and says, I'm out of that relationship, I'm done with them, you don't want to say, oh, thank God, hated him. You know, she was the worst person I've ever met in my entire life, right? Because on average, it takes a survivor upwards of 7 times of leaving and going back and leaving and going back in an abusive relationship to really leave and make it stick. So what happens if on the first time they come to you, they say they left and you trash talk them, then they go back? What is the likelihood that they're going to come to you again, right? And as tempting as it can be, trust me, even as a professional, it's tempting to do it. We have to take a second to stop and think that I am focused on the survivor right now. So that looks like helping the survivor find their own voice, let them know that they are intelligent, that they are a survivor, they are powerful, right? And then think about what you know. So if you're a student, say, I think you can probably talk to Safe Connections, there's this Title IX office, you know, you can talk to me, kind of provide options, and whatever they choose, advocate for their choice. And then please do your part to end this pandemic, right? as much as we encourage folks to do, safety planning when somebody's sheltering in place, right? The reality is we need our services to go back to full capacity. We need our shelters to be able to open up. Safe Connections, we want to go back to our office, right? We're all working remotely. We want to get our clients in because not everybody can do teletherapy, right? Not everybody is going to be able to do a safety planning phone call on our hotline in their home, right? So please do your part to end this pandemic. Wear your mask, wash your hands.
Okay, so we're going to talk a little bit about protective factors and strengths. What do you think you could do to help a survivor in this situation? Just put some of the answers.
Yeah, supportive things you would say. How would you approach it?
I'm seeing things like listen, always trust the survivor, offer them shelter, maybe.
Yes.
Yeah.
Saying, I'm here for you, I'm proud of you, I care about you.
Yeah, absolutely. Those empowering statements decrease that isolation.
Well, and let people know that you're there. All too often we hear people say to friends or family members that are in a bad situation, well, if you don't leave them, don't come talk to me about it. I'm tired of hearing about this. That is not helpful, right? You're breaking those connections and you're making them even more isolated. Please don't do that.
Yeah, a lot of students are saying non-judgmental, say I'm here for you, offer help or options and empathy. Tell them that you're not burdened by them confiding in you.
Absolutely.
Yeah. And then there's other sort of tangible referrals that you can point them out to. Phoenix, do you want to talk about these?
Most definitely. So the first one is our 24-hour crisis helpline. Someone is always there. The YWCA, they have crisis counseling over the phone, and they also have a drop-in center. Legal Services of Eastern Missouri, they will help folks with orders of protection. They have legal advocates. They are able to help with that. And then the program I'm working with is called Show Me Hope, and they have a disaster distress line. That is for folks that are feeling stressed, overwhelmed. They just need to talk to someone. They have counselors there that can help talk you through what's going on and help you kind of figure out if you need further support.
Absolutely. All right, so I know that time sort of flew by. Before we go into questions, I want to encourage everybody, especially if you're affected by this discussion, to please do something nice for yourself. Go on a walk, do some stretching, buy that cupcake that you've been eyeing. You're like, I probably shouldn't do it. Just go for it, right? Do something nice for yourself. All right, so let's get into some final questions.
Great, thank you so much. I really appreciate a lot of the take-home messages that you had here, which fit with what we've been hearing in this course overall, which is let's try and do everything we can to stop the pandemic, because that will help everyone who's in a difficult situation right now. And be kind to yourselves, be kind to each other. That's so important. And students were asking what they can do to help. And so I'm really glad that you ended with ideas about how to reach out for people that are in their lives. And I guess another question then would be for students who maybe they don't know anyone and they just want to know if there are things that, aside from stopping the pandemic, that they could be involved with to help. Are there good volunteer opportunities or things that you recommend students do to help out?
Absolutely. I am always encouraging folks to come join me and volunteer with Safe Connections. There is a lot of training that goes into being able to maybe answer our crisis helpline and things like that. There is Slavon is a fantastic resource, and Phoenix will talk about that in just a second, that can help get folks connected to good agencies. And I can't overstress, maybe overstate how important it is to be that voice in your circle that is talking openly about healthy relationships, right? And just keep saying it. I know folks are like, oh, that's cheesy, Jaszmine. No, I'm serious, really. Be that person that is constantly saying, oh, I saw that on TV. Yeah, that doesn't seem healthy to me. Because what that does is it tells somebody that might be overhearing you, oh, this is a safe person that I can go and talk to. Or it can be maybe reminding somebody that is abusive in their relationships, oh, this is something that I shouldn't be doing. You know, there's a lot of, as it stands, there's a lot of cultural acceptance, unfortunately, to abusive behaviors, to jealous behaviors and controlling behaviors. So we want to counter that message and keep saying it over and over, right, and doing it in your everyday lives. Phoenix, you want to talk about Slavon? Yeah.
I speak up quite frequently about like sexually assaultive or coercive behaviors I see on television. I'm pretty sure everyone I know is tired of hearing about it, but it's also really important to talk about it and let people know, like, that's actually not okay. Slavon is a group of all of the domestic violence agencies and shelters. We do large-scale trainings for folks that are going into this field. If you are interested in volunteering at one of the shelters, at one of the agencies, you'll see my email at the end of this. Just email me and I'll see if I can't get you hooked up with someone through Slavon. It's phenomenal. I'm really, really glad we have it.
Wonderful. I want to ask, I think we have time maybe for 2 more questions. So one of them is about students are wondering, it seems like given the situation, there would be an increase in rates of domestic abuse or intimate partner violence given the fact that we don't have these outlets and safety. However, at the same time, it seems like there could be a reduction in reporting through several mechanisms. Students have mentioned like a lot of reporting for children, for example, probably happens at school and they're not going to school. Also, there's no way to get away from whoever your abuser is to be able to call it in. Are there any data on what's happening in terms of if there is an increase, as so many people have hypothesized, and do we actually know that because how the reporting has been affected?
Yeah, so the Missouri Child and Abuse Neglect Hotline saw about a 50% drop, which is, and for us in the field, I always just assume it's an inverse correlate, right? If I see a 50% drop on the hotline, Safe Connections, we experienced almost a 30% drop when the stay-at-home orders came in. I know that there's probably a lot more people being abused. They can't continue to reach out for therapy. They can't reach out for help, right? Those folks that, like teachers, like school nurses who would report for them, they don't have access to those kids, to those survivors anymore. So yes, there absolutely has been a dip in hotlines. I know St. Louis County Police saw an increase. It's hard to judge though. They just saw an increase in sort of domestic disturbance calls, which can be a wide variety of things. But a lot of us across the state, and from what I can tell nationally, everybody has seen a dip in folks reaching out for services, and police have seen an increase in calls for domestic disturbances. Yeah.
That's really sad. I don't know how else to say it. That's really sad. So students are wondering then, for your organization in particular, how has Safe Connections adapted what they're doing or changed their approach during the pandemic?
I can speak a little bit. So I normally work in the education department at Safe Connections in Project Heart. The Project Heart and Groups team actually spent the summer rewriting curriculum to be able to offer classes online. So they are able to log on to the school systems, talk with students directly, talk to them about what a healthy relationship is, about communication skills, and give them that avenue that if they are in a bad situation, they can report it and get help.
Absolutely.
That's wonderful.
Yeah, and we've had a pretty aggressive marketing campaign towards about April, middle of April, beginning of April, to really put the word out that we never really skipped a beat. We're still doing the same work just from home, right? And luckily we did see a temporary increase in calls, and we had almost a double amount of the first time callers, those folks that are maybe atypical survivors. So maybe it is a 70-year-old man in a 50-year marriage and is just now realizing, oh, I think this is an abusive relationship. What do I do to get some help? So we really do rely on people putting the word out there and trying to get folks to contact us again.
That's great. I didn't realize that you had an uptick at that time, but I believe around that time I bought some very cool t-shirts that say "Love Shouldn't Hurt."
Yeah, absolutely.
I have a set of those as well.
Yeah.
Awesome.
They're great. They're comfy and they come in lots of styles. I highly recommend them.
Yes, they're so soft. I love it. I will also say we are lucky enough to be able to do telehealth with a large majority of our clients. So a lot of folks who were receiving counseling and support services, everything went on just like, well, not quite usual, but we're still able to offer services.
That's wonderful.
It is really great. Technology would be great for that.
Absolutely. And this. So we need to wrap up here. So I want to give you time to say some last words, but also just to thank you very much. This has been great information and we really appreciate it. So what are the last few minutes here? What would you like to end with, to leave the students with?
Well, first, I would thank everybody for coming, for being interested in the subject. On the screen, you will see a SurveyMonkey slide. This is how we're continuing to get feedback so we can continue to get funding. This is a 6-minute survey. Please, everyone, if you can just write this code down and hop on and fill out the survey, that would be fantastic. I want to stress that at the bottom, we have our 24-hour crisis helpline number if you want to call even immediately after this and decompress. And I really want to encourage folks, again, if you don't remember anything, remember empowerment advocacy, right? Remember to be that vocal voice in your community. And I just want to thank everybody for coming.
Thank you. We'll put that survey link on our Canvas site so that students don't have to write it down and they can just click on it. And I love that you say, you know, even if as soon as we get out of this class, you need to call. I think that that's great and I appreciate you doing that. So thank you both very much. This has been really wonderful and I appreciate you both being here.
Awesome. Thank you so much.
Great. Okay, so for everyone else, we will be back tomorrow. And until then, stay safe.